Okay, let's just start then. Good morning, everyone. Today we have a special cricket friendly schedule for all of you with not only one but two back to back sessions. Session one will cover regenerative endodontics by Dr. Lakshmi Pandey ma'am, and session two will cover post endo restoration by Dr. Priya Jain ma'am. So let's get started with session one on regenerative endodontics, proudly presented in collaboration with MedicalAura community. My name is Dr. Vishaka Singh, and I'm your host for today. Over this next 60 minutes, we will explore the clinical implication of regenerative endodontics and provide you with practical tips and takeaways. And it is my immense pleasure to introduce our speaker for today, Dr. Lakshmi Pandey ma'am, who is a renowned expert in the field of dentistry. As an assistant professor at SMBT Institute of Dental Science and Research, ma'am is dedicated in mentoring and shaping the next generation of dental professionals. In addition to her academic pursuits, ma'am is also the founder of Root Care Dental Clinic at Nashik, where she provides exceptional patient care. Ma'am is currently pursuing her PhD at Sharda University, Greater Noida. Ma'am is a distinguished researcher and speaker, having presented at numerous national as well as international conferences. Her research has been published in several reputed national as well as international journals, which lies and her passions lies in aesthetic dentistry and advancements in endodontics. We are honored to have you here, ma'am. So please start with the presentation.
Thank you so much, Vishaka. So I think, should I start the lecture now? I think most of the people have come.
Yes, ma'am, you can start.
So let's just start the lecture. Uh, See, all of you might be knowing, especially endodontics. See, this regenerative endodontics, we are now the era is turning into regenerative endodontics. So what exactly used to happen earlier olden days, we used to do root canals. Okay, the patient used to come to you with pain, and then you used to provide the root canal, and patient used to be pain free. But there were conditions in which the tooth is not fully mature. So what used to happen earlier, if the tooth is not fully mature and it has caries and all, so what the dentist used to do, they used to extract the tooth. So now you people know the era has turned into conserving what we have. That's why this regenerative concept has come. So my lecture will be divided into three parts. The first part will be I'll be talking about the basics, exactly what the terminologies and the most basic things in regenerative endodontics. Middle, I'll show you my case which I performed and with the follow up. And the later part, whatever I've done in my cases, those things I'll be elaborated in the further third part of the lecture. So let's just begin the lecture. I am Dr. Lakshmi, Assistant Professor, SMBT IDSR Nashik, and I am also a director at Root Care Multi-Specialty Dental Clinic. First, regenerative endodontics. So the first most important thing is, one minute. Oh, yes. See, the definition from Cohen is biologically based procedures designed to physiologically replace damaged tooth structure, first thing, including dentine and root structures, as well as cells of the pulp dentine complex. So this is the definition. The another the definition which you should know is tissue engineering, an interdisciplinary field that applies the principles of engineering and life sciences towards the development of biological substitutes that restore, maintain, or improve the tissue function. So, what exactly is tissue engineering? As you already know, it's tissue and engineering. So, tissue is something which is living, and when you incorporate engineering, principles of engineering in the tissues and the product which you get, which causes the development of biological substitutes and maintain and improve tissue functions. Here, what do you mean by biomimetics? It's the science of reconstructing or mimicking natural process or tissues with the expectation that regeneration will follow. Next, revascularization itself, it defines revascularization. It means you have to reestablish the vascular supply of immature permanent teeth. So, immature permanent teeth are the teeth in which the root formation has not occurred. Okay. Then revitalization, it's the ingrowth of vital tissue, that is the pulp tissue, that does not resemble the original lost tissue. Next, maturogenesis is physiological root development not restricted to the apical segment. The most important, repair. It's a healing of a wound in response to injury in an attempt to restore normal structure and function. Regeneration, it is a biological process where the continuity of disrupted or lost tissue is regained. See, repair is healing and regeneration is whatever that is lost is regained by a new tissue which restores structures and function. So let's just, see the difference between repair and regeneration. Your repair is healing occurs because remaining damaged tissue is vital. So whenever there's no vital tissue is not, in tooth, if nothing is vital, not even a single part of the pulp is vital, in that condition, repair doesn't occur. In regeneration, the damaged tissue is completely necrotic and then the regeneration occurs. Repair is defined as a process when healing takes place by proliferation of connective tissue elements resulting in fibrosis and scarring, whereas regeneration is where healing takes place by proliferation of parenchymal cells and usually results in complete restoration of the original tissues. It generates cementum, bone-like periodontal-like tissues closely or almost resemble normal pulp. Let's just know a little bit about history, how this regeneration started, and where it was, who found it. So first, the regenerative capabilities of a living creature was recorded in 330 BC. Aristotle, when he saw the lizard, he saw the lizard's tail grew back. So this was the first concept. Then Herman, 1952, he used calcium hydroxide in vital pulp amputation cases. 1961, Nygaard Ospey, he established that blood clot can be used as a scaffold for revascularization. In 1963, hemopoietic stem cells were, they were found and then they were used. Mayers and Fountain in 1974 attempted to regenerate dental pulp with blood clot. The concept of guided tissue and bone regeneration came given by Melcher in 1976. The application of PRP was also augmented by Casolis in 2000. And in January 2011, what ADA did was it adapted a new procedure code. So if you read that article, there's a very beautiful article in which they have written everything. They have given what are the, case selections, what are the procedures, what are the proper indications, the terminologies they have explained. So we already know the terminologies and we have known the history. Now let's just talk about what exactly are the goals. Why do you want to perform regenerative endodontics and why it is important? First thing, and the goals means when you do something, you should have a aim that I am doing this procedure. My, the outcome should be this. So these are the various, four goals. First is primary. It means it elimination. The most important thing when the patient comes to you, which have immature tooth, the patient will have pain or pus coming out. Sign and symptoms will be there. So what is the first thing that you have to do is elimination of symptoms. Evidence of bone healing should be there. It means even the lesion is there, the lesion should subside and bone healing should be seen. Secondary is increasing root wall thickness. So when you see a blunderbuss canal or immature tooth, you'll see that the root walls are very thin. So one of the goals should be when the walls will be thick, the strength will be there in the tooth. So increase the length as well as thickness. Tertiary, next comes the tooth should give you positive vital response. It means the vitality of the tooth is regained. And last, the most pinnacle of regenerative goal is histological confirmation to structural and functional restoration. It means when histologically, when you see the tooth, you'll have all the the contents of pulp or the regenerative cells that are present in the pulp will be present. So what exactly happens is, now till now we have done till tertiary, till tertiary it's easy to do. When you talk about histological conformation, it becomes very difficult, because to get a histological section you have to extract the tooth. So this is the problem. Next, the biological basis for regenerative endodontic therapy, it's a long-term calcium hydroxide treatment, was used earlier. You have read, no, that this open apex cases, the apexification, apexogenesis. So what, during that time, what we used to use, the calcium hydroxide. The success rate was 95%, but there were a lot of problems associated. I'll explain. The first problem here, as you can see, sorry, huh, the the bridge formation, or that that boundary that was there, or the bridge formation was very porous and was not continuous when we used the calcium hydroxide. This was the main drawback. That's why the newer bioceramic or silicate cements came. Second is long-term therapy for barrier formation. It, like, 3 to 24 months was seen with multiple visits. You have to give one appointment, two appointments were given, for calcium. 15 days, after 15 days, you have to recall the patient again and give the, calcium hydroxide again. Then mixed tooth brittle. This was the most problem, because if you give calcium hydroxide for a longer time, the chances of tooth fracture or the brittle increases. Why? Because of the hygroscopic and proteolytic properties of the calcium hydroxide. Then strengthening or reinforcement of the thin fragile blunderbuss canal is not achieved when we use the calcium hydroxide. So because of the all these problems which was faced because of the calcium hydroxide, we turned into a newer materials like MTA and biodentin. So MTA we used. What was the advantage? Second, reduces the treatment time, lesser visits with, you don't have to, replace the MTA again. It was more reliable. There were a lot of histological studies were done in which they found that the barrier which was formed by the MTA or biodentin, when compared with calcium, the barrier were more, continuous, and there was no porosity seen. So the success rate of treatment was as high as 94%. Still, studies are going on. So next, as you can see here, neither of the apexification treatment encourages further root development. Here, when we do apexification, see, this is a process of apexification. Once you fill this, the root formation doesn't occur here. So that's why, because of the apexification problem, we turn the, we shifted, or the new advancement came, that is regeneration. So this regeneration concept or the regeneration procedure have three most important, the three features or the three ingredients of the triad. First thing was scaffold, that was very much necessary, or the extracellular matrix on which this regenerative cell grew and formed the new tissue. The regenerative cells were the stem cells or the progenitor cells. And the third one was the signaling molecule or the growth factors, which, which help the stem cells or the progenitor cells to proliferate. As you can see, this is the scaffold. Here on the, wait, I think I have a pointer, laser pointer, yes. Here, this is the scaffold, stem cells, and here, this is the growth factor nutrition. So when on scaffold, these cells will go, this growth factors, the nutrient that is taken up by the stem cells, and then the regenerative tissue is formed. Now we have known the basics. What was the history? What were, what all were the terminologies which were used, and what are the triads, and what was apexification, why we went for the regeneration. Now I'll show you a few of my cases which I performed. See what happens. It's when you just continuously give a lecture, the theory basis lecture, it becomes very difficult to grab it. So 1 minute here. Yes. So I'll show you two of my cases in which I performed, and I explain you the problems which I faced. So clinically you'll understand, and I'll give you a few tips. After this, we'll continue the lecture, the theory part of it. This was a case, a patient, a 16-year-old patient came to me. Here, can you see this? The tooth were discolored. It was, discolored composite was also placed. When I took an X-ray, it was a blunderbuss canal within periapical lesion was seen. So under rubber dam isolation, and already inside there was a radio opaque material was seen in this. So I asked the patient, did you do any treatment before? The patient told, no, I went to some, doctor and they did some filling. After that, still after, 3-4 months back, he got the treatment done and still the tooth was paining. So the patient was having symptoms also in this. Under rubber dam isolation, I did the axis opening was done. After axis opening, uh, yes, here the case. I did the axis opening. I took a 15 number file. The explored the canal. After that, immediately I didn't do much of the instrumentation, and I directly used saline, cleaned the canal, and I placed a triple antibiotic paste. So before placing the triple antibiotic paste, I did the irrigation properly. The instrumentation was not done at all. Only I used 115 number file to negotiate the canal. After that, I used hypochlorite irrigation, and then I used saline. And this, I placed the triple antibiotic paste. You can see here, after triple antibiotic paste, the patient was recalled after, 1 week. And then I irrigated the canal here. Then working length determination was done. See, what happens here, the placement of triple antibiotic paste also becomes very difficult. So what I used in this case was this lentillo spirals. They are very good when you want to place anything inside the canal. So with low speed in micromotor, I use that lentillo spiral, and the triple antibiotic was placed inside the canal. That method was done. Why I did was to sterile, to make my canal, obviously there was a periapical abscess was there, so inside a lot of microbial, infection will be there. So to disinfect my canal, I used triple antibiotic paste. After irrigation was done, working length was determined. I didn't do much of the instrumentation. With this 15 number H file, I cleaned the, circumferential filing. I did remove whatever the soft tissue was present. Then I did the fresh bleeding. See here, all of you can see the fresh bleeding. I did a fresh bleeding. After fresh bleeding, we took the PRP of the patient here, and I injected the PRP inside the root canal. Then inside the root canal, and I placed the biodentine here, and then the composite restoration here. After 3 months follow-up, the lesion was little bit, started healing, and the root formation little bit, see, this regeneration process is also very slow depending upon the, what do you call it, the host response. So little bit healing, the symptoms were gone. Patient was not having any swelling, no pus discharge was there, and patient was clinically. So my primary goal was almost achieved in this case. And then the composite restoration, this is what I give it to the patient. And then later patient was called for the further follow-up. This is one of my cases. Then my next one more case here. Here, can you see a discolored tooth? Here also the patient was having a class 2, and the discolored tooth was there. Here patient was having pain. There was no symptoms of swelling or pus discharge, but patient was having severe pain. So radiographically when we saw, there was an open apex that was present. Open apex here. What I did the axis opening. Same in this case also, I used triple, I think I have not put the picture. I used a triple antibiotic paste for the disinfection. After the patient came, I did the working length. Here again, one problem comes. Uh, uh, as you know, there is no stop. The file doesn't stay there. So what I used a wax or, a cotton to, fix my file. And there are high chances that when you don't feel a stop, you might go beyond and you damage the surrounding tissue. So what I did, I took 2 radiographs. One was short. So after the first, we get a reference that how much should be the working length. So here you have to, here can you see? This was going beyond. So this was my reference. Then I did the working length. Ultrasonic irrigation was done for the cleaning of the root canal. Then fresh bleeding was here. This is what I did for the fresh bleeding. Can you see here? Fresh bleeding was done. After then, I took the PRP, placed it inside the canal, sealed it with biodentine composite, and this was again 3 months follow-up. You see the previous how the root was, and after 3 months how the root started getting can you see the closure here? So in this also, when you see the patient was symptomatic before, and after 3 months, the patient was not having any symptoms. And I did a composite build-up here. So the discoloration was also masked. So these were the two cases. So the takeaway point which I will tell you is your case selection is very important. See, what earlier people used to say that when you want to, perform a regenerative endodontics, the tooth has to be vital. There should not be any necrosis. But now, when the studies are there are a lot of regenerative procedures, are successful even in necrosis patient. The patient should be between 16 to 20 years of age. The healthy pulp should, no, sorry, the patient's host response should be good. And then here, the scaffold which I gave put was PRP. So the PRP played a very important role, and the fresh bleeding. So these two played a very important role for the regeneration of the cells. Next, let's just talk about here. So the characteristics of the three treatment procedures for immature, I have already explained the apexification by MTA, and the revascularization. So the study was done by Jurupan, in which what he found was the width and the length was increased by 28% and 14%, whereas in apexification and calcium hydroxide, there was not much root length changes was seen. As I have already shown in my case, area, you stimulate the bleeding, then blood flow canal forms a clot. This clot will become the scaffold. On that, I place the PRP. Then root formation is seen. So now I'll explain each and everything as a theoretical purpose. Now, see the case selection. So your case selection plays a very important role. Your tooth with necrotic pulp and immature apex should be there. Second, one minute. Yes. So age from 8 to 16 years, pulp space not needed. See, another one more thing is, whenever you're going to do a post and core, especially your custom cast and fiber post, in immature cases, your post and core is contraindicated. So whenever a tooth which is needed for a post and core, you should not perform. That tooth should not be saved and should not be performed for the regeneration. Your complaint of the patient is very important. Patient should not be allergic to the medication, especially your tetracyclines, which you use in your triple antibiotic paste. That also plays a very important role, because in this, your chances are pretty high that your medicaments are going to beyond the root canal. So if any patient who's allergic, the problem can occur. Next comes your disinfection protocol. So keep in mind that, see, when I showed you my first case, what I told you that I didn't do much of the instrumentation. Why? Because it was a blunderbuss canal and the walls are thin. So if you do aggressive, instrumentation, in such cases, the walls are very prone for the fracture. So open apex increases the risk of extruded materials also, because there is no apical stop. So the instrumentation should be very, should be done with a very lighter hands, and circumferential filing should be done to remove the debris from the walls. These are the medicaments that are used. Earlier, formocresol was used. Now it's not used. Triple antibiotic paste, double antibiotic paste, then modified triple antibiotic paste, in which we put the aminocycline instead of tetracycline, and the calcium hydroxide. Instrumentation, two types of cells are required to achieve a normal root development. One is odontoblast and epithelial cells. They are able to resist inflammation, and no instrumentation procedure remains consistent with vital stem cell preservation. So to preserve a cell, the instrumentation should be very mild. Then these are the various irrigants that are used. That is 3% hypochlorite, 0.12%, 2% chlorhexidine. Chlorhexidine, you have to be very careful because there are few studies that say that chlorhexidines are very toxic for the stem cells. So if you are using a stem cell, external stem cells, if you're putting, then chlorhexidine use is not indicated. Hypochlorite from the range, providine, iodine, and 17% EDTA. See, the 17% EDTA is also very important because there are studies recently, last year it was done. What it stated was 17% EDTA have the ability to, promote the cell, proliferation or growth. Next, hydrogen peroxide, it is a hemostatic action, act as antiseptic. Action is too short and it's quickly get neutralized, so the harm is also not present. And then problem is, if rinse to reduce pain and possible post-operative problem is gaseous emphysema. Chlorhexidine 2%, good action, absorbed by the dentinal walls, and the action is release, the substantivity property of chlorhexidine. Then sodium hypochlorite, we know 0.5 to 5.25%, but mostly 2.5% is compatible for us and best compromise between efficacy and lack of toxicity. Then again, next we come to iodine. Iodine is bactericidal, which we already know, providine iodine, antifungal, prurulent secretion, and blood do not inactivate it. Disadvantage, it discolors, the dental tissue. So it's not used. EDTA, better wettability, and induces a better penetration of irrigation and root canal medicaments. As I already explained you, it has a property also. There were a lot of studies that mentioned. It chelating effect will allow the release of growth factors. See, this is what happens from the dentine that would stimulate the proliferation of stem cells. Ring et al. Have compared chlorhexidine hypochlorite after the treatment of EDTA, and they shown that there is no survival stem cells after using the combination of EDTA and chlorhexidine. So you should not, use combination. Next comes our disinfection protocol. So what I used was triple antibiotic paste. You can use calcium hydroxide also. This calcium and hydroxide induces, see, this property you already know what exactly the hydroxide does and gives the property to the calcium. It's calcium hydroxide. Damage the cytoplasmic membrane, suppresses the bacterial enzyme, denatures, damages the DNA of the microorganism, inhibits any replication. It increases the expression of some kinases, which are indicator of proliferation of stem cells. Therefore, used in usual concentration, it would not be cytotoxic to the stem cells. Now, as I've already told you, it is going to be replaced by a lot of tricalcium silicates like MT and biodentine. Then again, 0.001 milligram per milliliter calcium hydroxide for canal disinfection allows survival of 100% of apical stem cells. So the toxicity is not mostly present on the stem cells. Next comes the triple antibiotic paste, which I used in my case. The combination of antibiotic is essential, obviously. Uh, Another thing was the balance, the concentration of for a balance between a lower cytotoxicity against stem cells and a maximum bacterial infection should be done. So it's not like you'll take, you know how to make a triple antibiotic paste, right? You have to take all the I think I've mentioned, I guess. No. So, what exactly you have to do? You'll get the capsules. You'll use saline. See, there are a lot of vehicles are also used. You can used for, glycol or saline. You can use as a vehicle. You can mix it, and it is freshly prepared. So when you're using a saline, you should freshly prepare it, in the dappen dish, and then you have to use it directly immediately in the patient's canal. So an in vitro study shows that triple antibiotic concentration would be best 39 microgram per milliliter, best for the application in disinfection root canal. So propylene glycol, as I have already mentioned, as a vehicle, it is used. Most of the revitalization regeneration procedures uses triple antibiotic paste, which is called as Hoshino paste, as I explained here. See, minocycline should be 100 gram. 100 milligram, ciprofloxacin 200 milligram, and metronidazole 500 milligram. So Hoshinos gave this mixture, and carrier you can use macrogol and propylene glycol, and you can mix it and you can use it immediately in the patient's mouth. Limitations are bacterial resistance, we know because we are using antibiotics. Some of the patients are allergic. Most important limitation was the discoloration that was seen due to tetracycline. So later it was replaced by minocycline. Binds to calcium ion by chelation and form insoluble complexes, discoloration. No, actually, minocycline was the one which used to cause discoloration. So we use the doxycycline in place of minocycline. So the discoloration of tooth is very less with doxycycline. Persistent sinus tract after using triple antibiotic base was also seen in most of the cases. Next comes your tissue regeneration. Thickening of root walls may be of different nature, dentine, cementum, or even bone. Therefore, this procedure is not a process of pulp revascularization, but a process of tissue regeneration. So, uh, as we have told about, well, what is revascularization? As I explained, it is the regrow of the blood cells, or the blood flow of the root canal is maintained. So, in some cases, how do you check it? You can use a laser flowmetry, and you can check it Doppler flowmetry. Another thing, what we radiographically see is we see the thickening of root walls, or the length of the root. So this becomes as a tissue regeneration. Then the most important part that comes, see, you do a procedure, you have done, everything was excellent. But how do you know that your procedure is a success? It's the follow-up and the treatment outcome. So resolution of apical lesion is mostly seen in 6 months. Root thickening closure is 1 to 2 years, 12 to 24 months. During the first year, the first three patients you should call 3 months, then 6 months, then 12 months, then 24 months. So you have to keep a follow-up, which plays a very important role. Most revascularization were performed on incisors and premolars, mostly 8 to 14 years of age. So the initial age plays a very important role. As you go further, the success is very controversial. You know what happened when I started reading about the revascularization? There was a lot of articles were there. What they were mentioning, that the age doesn't, hamper the revascularization or regeneration. Why? Because we are already externally providing the scaffold or the stem cells. So if you're going to provide a stem cell scaffold and all the three triads are present externally and you're providing it, the chances of regeneration were there in such cases. So as Shah et al. 2008, they mentioned successful revascularization case report in older ages. Then comes your unfavorable outcomes. Lenzi and Trope 2012 found empty root canal spaces after treatment of an immature maxillary sensitizer with a necrotic pulp. So if it's not favorable, if the regeneration has not happened, the root canal is empty, and there you'll find a lot of necrotic tissue and infection. Showed that the absence of vital tissue inside the root canal space of treated immature maxillary incisor with necrotic pulp after 6 years. So after 6 years, patient was not having any symptoms, but inside the root canal, the patient was having necrotic pulp. Presence of presented a case where a root maturation occurred in a maxillary incisor, even though regenerative endodontic process resulted in an empty root canal spaces. Even after using tissue engineering strategies, cementum like hard tissue was deposited on the root canal wall, and formation of hard tissue barrier inside the canal between the coronal empty plug and the root apex. So, these are the unfavorable. It means the patient was not symptoms, but radiographically or histologically, when they checked, inside the root canal, it was empty, necrotic tissues were seen. So, our treatment outcome was dependent upon the chemical disinfection. See, whatever you do, your first aim should be remove all the microorganisms from the root canal. So how you do it? You do it with disinfection. So I have already mentioned what are the disinfectants you can use. So a very good disinfection will obviously lead to a good regeneration. production of a suitable environment for a scaffold to support tissue ingrowth. See, a lot of times what happens when we provide the scaffold, what happens, these as you know, there are a lot of osteoclasts are there, or a lot of cells, healing cells are there. What they used to do, they used to, eat up the scaffold, and you never used to have a scaffold for the cells to grow. So this was the problem. So the scaffold plays a very important role. And the most important, the tight seal should be there, that the lot in your mouth, microorganisms are present, and your tooth is prone for micro leakage. So your seal plays a very important role. So if you provide all these three things, the chances of your regeneration increases. It requires a shorter treatment time. After control of infection can be completed in single visit. Yes, it's cost effective. Why? Because number of sittings is not there. Obturation of the canal is not required. If you were using it, after epixification you were supposed to do, and continuation root development is seen. Limitations, long-term clinical results are yet not available. People are doing, a lot of studies are there, but 10 years or 15 years follow-ups are still not there. The entire canal might be calcified, compromising aesthetics and potentially increasing the difficulty in future endodontic procedures. Some cases, if resorption process is there, so they become very difficult. In case of post-encore and the final restorative treatment plan, revascularization is not the right treatment option. Factors that affects the result of revascularization: degree of infection, apex diameter. Yes, that is another most important thing you have to keep in mind. The smaller the opening, the chances of revascularization is good. An open apical foramen more than 1.1 mm is beneficial. Possibility of increases in approximately 18 to 34 of teeth with immature root. Age of the patient 18 to 16 years I've mentioned, and revascularization should not be performed on a deciduous tooth. The contraindication. See, this was the base. How I have done, I explained you. Now, there are various other therapies which resulted in regeneration. That was postnatal stem cell therapy, the simplest method to administer stem cells. It can be derived from various your skin, your mucosa, or your bone. The major research obstacle was, capable of differentiating into diverse cell population found in adult pup. So what was the problem? See, you have taken a stem cell. How that stem cell is going to differentiate later, we had no idea. So this was the major research problem was there. This stem cell is going to differentiate into a collagen or a fibrous tissue or a bone. Then it's fine. If you have taken, you want a bone growth, or you want the walls to thicken. In such cases, if a collagenous differentiation occurs or endothelial cells occurs, it poses a very big problem. Technical obstacles include the development of methods for harvesting. Obviously, to harvest stem cells, it's difficult. Disadvantages: cell may have low survival rate. Sometimes you put the stem cells and the survivability is not there, and it is eaten up by the osteoclast. The cell might migrate to different locations, leading to aberrant pattern of mineralization. True. And the possibility of producing new functional pulp tissue by injecting only stem cells without, see, if from the triad, if even a single thing is absent, your regeneration process is not going to occur. So if you have given stem cells but the scaffold is not very proper or it's not present, such case your cells are going to die. Then next again is pulp implantation. It's another method that is used for regeneration. The majority of in vitro cell cultures grows as a single monolayer attached to the base of culture flask. In theory, to take 2D cell culture and make them 3D to the pulp cells can be grown on biodegradable membrane filters. Problem was may be required to roll together to form three-dimensional. Here, see, 2D culture was done, then stem cells niche artificial 3D matrix was made, and then this is 3D culture that was there and was incorporated in the cell. So that placing inside the canal was also difficult. Advantages: the cells are relatively easy to grow on filter paper because the filter acted as a scaffold, and aggregated sheet of cells are more stable than dissociated cells to administer. Disadvantage was specialized procedures may be required, definitely. Sheets of cell lack vascularity. So only the apical portion of the canal system would receive these cellular constructs. Because of the filters are very thin layer, they are extremely fragile. So placement inside the root canal was very difficult. I've already mentioned that. Another one is scaffold implantation using a porous polymer scaffold. These are the artificial scaffolds which are used, in which the pulp stem cells were implanted. And then the scaffold should contain a growth factor. Obviously, the three things: growth factor, pulp, stem cells, and the scaffold, and they were placed inside the root canal. Uh, see, pulp cells are seeded onto the 3D scaffold. Structure supports cell organization. Some materials may promote vascularizations also. Uh, Next was injectable. See, just because of delivery problem, it was very difficult to deliver the scaffold or the cells. There was another injectable scaffold was present. Rigid tissue engineering, excellent support was there, but the placement was a problem. In root canal system, a tissue engineering pulp is not required to provide structural support of the tooth. This will allow tissue engineering pulp tissue to be administered in a soft 3D scaffold matrix such as polymer hydrogels. Hydrogels are the injectable scaffolds that can be delivered by syringe. Here, can you see? This is syringe you are putting the scaffold. Past problem with hydrogel included limited control over the tissue formation and development. A lot of studies did not prove that with this the actual regeneration happened, but advances in formulation have dramatically improved, and then it has supported the cell viability. You can see the injectable hydrogel carrier is placed. Dental pulp stem cells, alginate microsphere containing growth factors here inside. Then you place it, root formation occurred, empty barrier, and restorative material. To make hydrogels more practical, research is found on making them photopolymerizable to form rigid structure once they are implanted into the tissue site. Next, another thing was 3D cell printing. In theory, this thing has not yet been done. See, I was telling later, till placing the your liquid or your injectable scaffold, it's there. 3D printing cells are still going on. Inkjet-like devices used to dispense layer of cells suspended in a hydrogel to recreate the structure of tooth pulp tissue. Ideally, odontoblastoid cells should be placed around the periphery to maintain and repair dentine, with fibroblasts in the pulp core supporting a network of vascular and nerve tissue. So, what exactly it happened in 3D printing? They try to regrow everything: your fibrous tissue, your vascular tissue, as well as your bony tissue and nerve cells. Precisely positioned cells. Careful orientation should be done. If the orientation is not proper, asymmetry will be there. The nerve tissue will be growing somewhere else, vascular tissue will be growing somewhere else. Last, the most important part of my lecture is the challenges and the future direction. So, replaced pulp may also become susceptible to further pulpal diseases. So, if the patient is not maintaining the oral hygiene, how much you do, in the end, even after the treatment, the tooth is prone for uh, and further infections. Enhanced microbiological control method required for adequate tissue regeneration. Yes, technology is that is needed. It is very skill technique sensitive. It's uh, very enhanced. Current culture condition and the nature of microenvironment in which the primitive multipotent pulp stem cells are maintained and expanded limit the success. The more complex root canal anatomy will require more complex scaffolds. See, single rooted is done. If you are planning for a multi rooted, especially molars, the challenges will be more. A way has to be found to ensure that these transformation and growth will not continue beyond control when implanted. True. Matching the aging of the implanted tissue engineering parts with that of surrounding tissue and organ. Patient and parents should be informed about the potential of minocycline in the triple antibiotic paste, especially the anterior tooth. The discoloration part should be mentioned. So, what I want to explain you is, see, this is a new concept the techniques or the armamentariums or the harboring the cells or harvesting it, preserving it and using it, or the delivery method, everything is very technique in advance. So this also poses very challenges, and the cost that is the patient has to bear, or you have to bear for your studies, also plays a very important role. So further newer method should be available, in which the cost, it should be very cost effective, so that it should be done at a larger scale. And another thing is the follow up period of studies like this are not still, it's not there. A huge controversy is there that some of the regenerative procedures are successful, some are still not success. Even after 6 years, we see necrotic pulp and all. So conclusion is, there's considerable debate on the ideal outcome. I've already mentioned. There is a gap between the expected histological outcome and actually happening in the root canal. So what exactly it means is, you are doing a treatment, a regenerative procedure. The patient is asymptomatic and everything, but to actually know the histological, the final goal, which I mentioned in my initial lecture, the final goal was is still in uh, that blur area, because to know the final histological, you have to extract the tooth, and if you extract the tooth, there's no point for doing the entire procedure. So since many of these teeth achieve acceptable clinical outcomes, being infection free, asymptomatic, clinically function, it seems logical reframe our perspectives in the field and expand the scope of definition of success in endodontic regenerative treatment, and consider the aforementioned clinical outcome as success. These are my references, and this is my clinic, this root care. So if you people have any doubts and all, you people can, message me on Instagram, also mail me. I would like to conclude. Thank you so much for patient hearing. I think now I would like to take up. Anybody has any doubts?
Yes, ma'am, we have few questions actually.
Wait, let me
I'll just read
start.
out.
Just read out. Wait, let me.
Yeah, there's a first question by Dentistry ZN Dent.
Hmm.
Revascularization versus epexification for a
Yes.
necrotic immature tooth. What are the key clinical indicators that would make you choose regenerative endodontics over MTA epexification? Are there specific cases where epexification might still be preferred approach?
Yes, actually, let's just start. There were a lot of questions were there here. For a necrotic immature tooth, what are the key clinical indicators that you should make choose regenerative? See, when you were doing epexification, which I mentioned, was you have to use, MTA or calcium hydroxide, and a barrier is formed. And then you fill the barrier, the entire root canal with the obturating material. In that condition, epexification, the root length is not increased, and even the walls are not thick. So if you're performing epexification in cases where the walls are very thin and root length is not enough, such cases your tooth is prone for fracture, because your tooth won't be having that much of strength. So if you have a patient, especially, see, performing a regeneration in your clinic is a quite difficult process, because first thing, you have to convince the patient. uh Chances of failure, because there are still controversies are going on, so the failure chances are still high. So if you take up a lot of money from the patient, or you perform these steps, and even the result is not there, so the patient trust also goes in cases like this. So what I am saying, the clinical indicators. So if I'm seeing a very healthy young patient around 8 to 16 years, patient, tooth is not having, tooth structure is there, it's not going for any post and core. Such cases in my clinic, I'll explain the patient, I'll explain that the chances are there the tooth length is increased, or the walls will become thick. In such case, if the patient agrees for the treatment cost or the procedure, you should go for the regenerative endodontics. If the patient is not willing, first thing. Second thing, if you if you are seeing that the patient is also not going to turn up to you for further follow up. See, the patient doesn't have to come for the procedure for multiple visit, but the patient has to come to you for follow-ups. So if you see a patient who's very reluctant for follow-up, such cases also performing a regenerative endodontics is not fruitful, because you won't get to know the end result or the outcome. So these clinical indicators, the age of the patient, the patient's acceptance, and the patient response, you have to keep in mind. This is the first. Second, are there specific cases where apexification might still be preferred? Yes, if the blunderbuss, if the apical opening is not uh, you know uh, if the thinning of wall has not happened, or if the opening is not very big, it's like if the opening is around point one around 1 to 2 mm, in such cases you can go for apexification. When you know the root strength is there, in such conditions, you can always go for apexification. It's still performed. MTA gives a very excellent apexification. Then next question. Any you have any further doubt in this? Okay, fine. Next, in case of necrotic immature molar within apical diagonal. See, again, the same question which I mentioned. The factor, see, traditional MT apexification you can do. What is the specific? I told you the age of the patient. Okay. The if the patient is not having any allergy or systemic problem, the host response is very good, and the patient acceptance is there. In such cases, you can always go for regenerative endodontics. If the patient acceptance is not there, because you will be needing that patient for at least 1 or 2 years, minimum at least 1 year, to see the success of regenerative endodontics. In between, if the patient will have any flare up or any failure, you can always go for further MT apexification cases. Can artificial nails plays a role in? Yes, it's a very good question. Yes, artificial intelligence can, yes, it can be used to predict the success, especially in the radiographic. The radiographic, uh, when you see the radiographic success in which the length is increased or the thickening is there, to determine that and to better read it, artificial intelligence can play a very important role, can be used. Any further questions?
Ma'am, there was a question you missed
Uh-huh.
actually. If regenerative endodontics continues to evolve, do you think it will eventually replace traditional root canal therapy in young patients? And what are the key developments need to happen for this shift to occur?
Where is it? I didn't see.
Ma'am, just before this AI question.
Um, okay, yes. Uh, yes, actually, see, your question is very. See, what exactly happens is, your regenerative endodontics is something which is new, something that is new, and everybody is doing it, researching it, because we know natural tooth is much and always better than anything that is artificial or replaced, or, so your regenerative, it's evolving, studies are going on. There are high chances, yes, if more studies like 15 years or 20 years follow-ups are there, proper procedure, steps are there, defined, or studied, or in the end given the ideal steps to do it, it's better to go for regenerative endodontics than your conventional method. You already know, right? Anything that is conventional, it's good, but even after you have a case, the patient comes to you, depends on your patient's acceptance, depends upon your how if the patient is very old patient, in such cases, and the patient is not able to sit, or the patient is not going to come for the follow up, such cases you cannot go for regenerative endodontic cases. What key development needs to happen to this shift occur? See, the key, replace traditional root canal therapy. See, root canal therapy is totally different than regenerative. See, root canal therapy is includes your direct or indirect, indirect pulp capping or direct pulp capping, or the pulpotomies and all. See, your regeneration is not going to replace it. Your See, if you have a pinpoint exposure, it's always better to do a direct pulp capping than to do the entire regenerative procedure. See, I don't, if you must have read the 2003 article by Rungta ma'am, what she has mentioned, if the root closure is not there, and if there's a exposure is not there, necrotic pulp is not there, in such cases also, if you go for direct or indirect pulp cap therapy, there are high chances of root generation or root length thickening or periapical closure. So your regeneration, you can say like that, in immature pulp where the pulp is necrotic, you know, where you have to externally provide your necrotic, those three triads. Such cases regenerative. Even in root canal therapy, where the root formation is not there, you can use the direct, indirect, or pulpotomy. There were cases in which the coronal pulp, what they use, they removed the part of the coronal pulp, they sealed it with biodentine, and then the root formation occurred. So eventually, you can see, yes, root canal therapy is further into a regenerative endodontics. So it's not going to replace it. And what are the key developments? Yes, further studies is needed, more labs for providing the scaffolds or the stem cells is needed. uh, yeah, follow-ups is needed, because we need to know what exactly is the outcome. See, the process is defined, the steps are given, but the most important part is, we should know the outcome, because when you're working in a clinic, uh, the patient will see the outcome. Patient, is not bothered that you have done the step very nicely. The patient clinical symptoms should be relieved. Patient should, for 10 years or 15 years, a patient should not come to you for any problem related swelling. So, we have to see the procedures or the steps or the advancement, but in the end, we have to see the, patient's viewpoint also. So, yes, the outcome or the studies about the outcome is needed. Any other further questions, Vishal?
No, I guess we are done with the questions.
Okay. So I think we are done with
Yeah.
the test. Anybody wants to ask any question? See, it's a very new topic. The theory part becomes little more dry. Obviously, it's very dry. See, in dentistry, anything that you have not done or you don't do, it becomes very difficult to understand in a theoretical, manner. So that's why I showed you my cases, how exactly I've done. If I would have just told you, no, I have taken the working length, I have placed it. But when you saw exactly how it's done, it becomes easier to understand. So I've placed my cases also.
Yes, thank you so much for your time. And we were actually very grateful that you took your time and just like enlighten us with this newer topic. And it will definitely help us to incorporate in our dental practice also.
Yeah,
Thank you so much, ma'am.
I'll suggest all the PGs to do at least one or two cases. It's doing is very easy. And the most important, you should keep a follow-up. So, yes. So,
Thank you so much.
thank you so much.